So these folks, again, they're going to have, you're going to assess their response to therapy, looking at disease activity markers, just like we did with the mild. We're going to also be looking for medication toxicity. Methotrexate is a very toxic drug, so making sure they get in from lab and that is reviewed and adjusted accordingly. Disease resistance. Let's look at those. People who are disease resistant will usually have persistent inflammatory symptoms. So the thing the approach that's used is adding a glucocorticoid or using the intra-articular in the bigger joints. It will depend on the number and the ones most effective. You don't want to inject every joint, it would be too many. And the burden of the steroid would be too high. But those are things to consider if they're not responding. Disease resistant to initial DMARD is characterized by these three things: failure to achieve remission or low disease activity within 3 to 6 months, failure to achieve remission or low disease activity and requires steroids. And I gave you an amount. I'm not so much concerned that you know that, but that you recognize that if people are having to continually need steroids, that there is either a disease resistance or they need a higher, they usually need a more potent DMARD. Or the number of times they need a burst. Think about asthma. Remember with asthma, if the inflammatory response was not well controlled, they just needed multiple steroid bursts. It's a similar type of thing here. So they're needing steroids or they're needing multiple bursts of steroids on top of what they're already taking. Tells you that it's either disease resistant or you're not treating them with the appropriate medicines. Approach to disease resistance. So I've alluded to this. It's moving to combinations. So we can use combinations of non-biologics. So the methotrexate, hydroxychloroquine, sulfonamide, that's referred to as triple therapy. It's been studied, it's fairly well tolerated. It is one of those things that you can use before going to a biologic. Or you could use a combination of methotrexate and a TNF-alpha inhibitor. Those are for people that have high disease activity, adverse prognostic indicators. That is a powerful combination. It is a powerful side effect combination. So with leflunomide, sometimes they will switch if they're not responding to methotrexate, and some people don't. Some people don't go into remission on methotrexate. They will try Arava. In my notes I have, sometimes they will put those together. That would be a last resort. That is something you would like to avoid. They are both very hepatotoxic. You really would not want to do that unless there was no other course. Duration of therapy, on next page, this is where I think you would need to pay attention to your patients. If you can get people into remission, especially if they can go into a deep remission, let's say their numbers fall and their disease activity is really low and they can stay there, then after a period of time you can look at decreasing the medication, backing it down, tapering it down. It would be rare that people could go off medicine, but there are some who can. Oh, and I have it in that last bullet. So that last bullet shows you. So people who are very early in disease, males tend to do better than females, so males more likely. Let's see. They don't have rheumatoid factor or CPP. They've had very appropriate, intensive, aggressive therapy that's gotten them into remission fast. They've gone into that deep remission and stayed there. Those folks have the best chance of coming off the drug and staying in remission. That's why I'm telling you, if you see people and they've come off their drug then probably it's for another reason. And that's part of your job, is to figure that out, or hand them off to someone who can figure that out. Okay. I can tell you that was a lot of my job, was just figuring out why people aren't taking what they're taking. It takes a lot of time. Good Shepherd, you've been exposed to that. You see people off their drug all the time. Haven't every one of you had somebody come in and they're not taking their drug? So most of the time, once we get them to remission, we're going to keep them there. And we will back off very slowly. So we aggressively go at them and we slowly come off of it. The things you're going to come off the most is you're going to try to get rid of the steroid, number one. The biologics, they're probably going to have to stay on something of that if they have any moderate to severe activity. If they have very low disease grade, then they may be able to come off medicine. Highly unlikely. Questions about those? That's the overview of RA. Now what do you think? We didn't even talk about the bad boys. We'll do that just at the very end. Okay, let's move to lupus then. So lupus, another autoimmune disease, much more likely in women, young women, than men. Unknown cause. That really bothers Boomy. She's always like, how can they go forward if they don't know? Well, we just do sometimes. So it will hit a variety of organs. It will hit, and it shows you the picture there, they get multiple organ involvement. Usually they will have a predominant organ that's involved, like lungs or kidneys, very common. The picture that I've showed you there is called a butterfly rash. It's one of those, it's kind of pathognomonic for lupus. Not everybody, rosacea, there's some other things, acne can kind of give you that, but that butterfly rash, young woman, you would want to think about lupus and rule that out. We want to prevent the flares, prevent and control flares, but the big thing is we want to minimize those complications from the lupus. Here, the drug of choice is hydroxychloroquine. That's great because most of the women are young. So this is good. It will relieve their constitutional symptoms, so their aches, their fatigue, musculoskeletal, so the joint involvement, mucocutaneous manifestations, so that's kind of keep Kathy in mind because she's told you she has discoid skin lupus and the hydroxychloroquine addresses that. So it's a great drug because it's not as causes as many troubles as some of the other biologics. You can use it in combination with a non-steroidal or a steroid, so we use those similarly. We use them for controlling the inflammation or symptoms that would respond to inflammation, and also we can use them as bursts when they have flares. Mild lupus can probably be taken care of mostly with hydroxychloroquine, but when you get to moderate, now that is when they have organ involvement that's not life-threatening. Those folks usually need a combination of products, so hydroxychloroquine plus prednisone. Here you'll see much more steroid used in combination at low doses than you will with RA. Low-dose steroid is considered 5 to 10 milligrams a day. 5 milligrams is considered somewhat physiologic. So when you're starting to get above 10, that's when we are usually treating much more higher inflammatory response. Once people are stabilized, we usually will try to back them down to the lowest amount of steroid that will keep them from having a flare. When you get to moderate and severe lupus, we start introducing immunosuppressants. And we use those to induce a remission, and then sometimes we'll bring them off of it. We also use it to cut down the amount of steroid we have to use. So the immunosuppressants that we use are on the next page, kind of there in the middle. The mycophenolate, cyclophosphamide, azathioprine is probably the one that's been around the longest. Rituximab is actually a TNF alpha, or a non-TNF alpha, sorry, biologic. These folks will probably have more pulses or burst of activity with the steroids as well. Okay, so we're going to use an immunosuppressant to induce remission. Then we're going to put them on and steroids. May have them on hydroxychloroquine as well. We'll move them down to as low a dose as a steroid as we can maintain them, and we may also maintain them on that immunosuppressant. So that's what the combination looks for more severe lupus. There is one biologic that is targeted for lupus, and that's that Benlysta. It is used when all other drugs they fail to respond fully to all other drugs. So it's last resort drug. Under non-steroidals, the same kind of musculoskeletal complaints we took care of with RA, it's the same thing. So the arthralgias, even a pericarditis, inflammatory type symptoms can be handled with a non-steroidal. Again, just like we saw in RA, they do not change disease activity. That's a very important point because it isn't going to do us any good. It just treats the symptoms, it doesn't treat the cause. You're going to see a lot of lupus nephritis, so in those folks you would avoid using the non-steroidals. We use a steroid instead. For the corticosteroids, we can use them. They're great anti-inflammatories. We're just going to try to limit how much they need. Here we would start high doses and taper them off to the lowest dose that will control symptoms. If they have big time organ involvement, kidneys, lungs, then they may be on daily steroid. Azathioprine, that's the one thing I want you to mirror about those immunosuppressants. I want you to remember that we use them for induction, get them to remission, but that we usually continue them on to help with maintaining remission, but it's that cutting of that steroid dose and getting it down low is very significant. When I was a young faculty member at the College of Pharmacy, we had a young woman that had lupus, and she developed a cerebritis and died. It was sad. She had 2 young children, young woman. Okay, page 16. Let's see. CellCept, very powerful or immunosuppressant, often used to induce remission. Azathioprine can be used as well, but CellCept has become more common. Also in the treatment of severe lupus nephritis. Cyclophosphamide, another immunosuppressant, has been around forever, still used. Again, you'll see the lupus nephritis come up quite often, and then methotrexate can also be used for its steroid-sparing activity. Comments there? I think everything else that's in there I've said at least once or twice. Comments there? Okay, that next section, safety issues and monitoring. I gave you objectives for it, but I'm just telling you, know the whole page. I hardly ever tell you that, but I'm just telling you. This, I have gotten it down to the bare bones, and it's all important. And it's the thing that I think is really important for you all, because I think that's where you're going to play a big role. So let's walk through that. So we talked about what to obtain before. That's a repeat of what I put in there first. And then the repeating is every 2 to 4 weeks initially, especially with all of them, but methotrexate and leflunomide and sulfasalazine. So discontinue. So those two, methotrexate and Arava, One thing you're going to be looking at is platelets and white blood cells. So remember I told you those drugs are very myelosuppressive, so they wipe the bone marrow out. If they reach those levels, you discontinue the drug. So they're either going to be running fevers or they're going to be bleeding. So you would be checking a CBC. If you see that, you stop the drug. The list of contraindications is huge. So sulfasalazine if the platelet count is less than 50,000, so low platelets. We don't restart if the LFTs are 2 times above normal. Now that's different. Usually we give you 3 times the upper limit of normal as being the more common for a lot of different drugs, but here it's 2 times the upper limits of normal. If they have active Hep B or Hep C, if you put them on these drugs, those diseases will just rage and can kill them. Serious bacterial fungal infection or herpes zoster, contraindication. Did I put down here AIDS? You might add AIDS to the side because that is also one of the things you're going to be looking for if they've got an upper respiratory. Any infection, if they have an infectious process, that needs to be cleared up before you start them on the drug. If they have demyelinating disorders like multiple sclerosis, you would use this drug. Renal insufficiency, for both of those. Pregnancy, we've talked about those 2. Blood dyscrasias, methotrexate's really powerful. So following the CBC is important, and platelets. The very last, you've got to vaccinate these people before you put them on the DMARDs. Okay. So Hep B, your age group probably has had those series, but older folks may not have, so checking and making sure they've had that. Influenza, so FluMist we don't use so much, but you don't want to use any live vaccines. You want to use attenuated or killed. The pneumonia, you're going to give them Prevnar 13 and Pneumovax 23. I don't know that it matters so much which direction, but usually we'll start with Pneumovax 23, and within the next year you need to also give them that Prevnar. The CDC outlines how those sequencing of those drugs are given. You want to also do a human papillomavirus, like Gardasil. Herpes zoster. So this one you have to wait at least 2 weeks after the zoster vaccination to begin the biologics. So that was just a little bit different. Don't use the live vaccines. Questions there? Know all of that. I guarantee you it will pay off in the test because that's the first place I'll go tonight is when I start writing. Okay, I think with the methotrexate, everything there is a repeat. I think I've given you all of those. It goes into more detail in that mechanism of action about the folic acid and how it disrupts that pathway. Contraindications are the same. Let's go to the next page on 19. You can kind of overlay methotrexate and Arava. They're very similar, but they have some differences. This drug is very hepatotoxic, so making sure you have that those baselines to rule out any liver disease that you could make them worse. So the adverse effects, what I would do is learn those underlying areas. So serious liver injury or hepatotoxicity, severe infections. You also can get a peripheral neuropathy. As far as I can remember through all the drugs, this is the only one that does that in this group. So it kind of stands out. And it is a pregnancy category X. This drug is interesting because once you start taking it, stays in the body for a long, long time. It takes 2 years to get rid of all of it once you stop taking the drug. So that has some interesting problems if people want to get pregnant or they run into like the immunosuppression or the hematology. So if you look at both of those, it talks about using, if you have to interrupt therapy, using cholestyramine or Charcot. Do you remember cholestyramine? we didn't talk about very much. It's a bile acid sequestrant. It's the first one on the market. We don't use it very often anymore, but it's still around. It has various uses. So you can use it to lower cholesterol. When people have a lot of itching from liver disease, we will often use that as a way to help relieve the itching because it binds up the bile acids. So this will hasten getting rid of the drugs. So if someone wants to conceive, you would use this to help elimination, or if you have a myelosuppression or an immunosuppression that you're wanting to combat or having to stop the drug, that can be used. So that's different. So that should be an easy one to remember. Reliable contraception, very, very important. This is a big X, category X drug, as well as methotrexate, very teratogenic. So if they stop it, they need to wait at least 2 years before they try to attempt a pregnancy. Questions about those? We're almost done. I'm always amazed. I'm always worried about some things that I won't get through and then I go too fast. Okay, on page 21, let's talk about Plaquenil. So we talked about it being first line for low disease, mild, early onset or early disease in RA, and then also for SLE. Skin manifestations, musculoskeletal we've talked about, maintaining remission in lupus patients. One of the few drugs that can be used during pregnancy, so kind of keep that in mind. The adverse effects is the most important, the one I want you to put some stars around. So it's the retinal toxicity, and it is dose related. So there's an accumulative dose at which the risk goes way up, and that's at 6 grams per kilo. So if you had somebody who weighed 70 kilos, so that's an average size reference, so that's about 150 pounds, and you can take the dose of this drug is about 0.4 grams a day. How long could you take it before you would reach that cumulative dose?
20 days.
I know, it's math on Friday afternoon. So 6 grams per 70 kilos would be what?
420.
420 grams, and you can take 0.4 a day. How many days is that? So I get a calculator. It's about 1,700, something like that. Come on, you all have calculators. Pardon?
150.
No, it's not that.
1050. It's 1050.
Sorry.
Is it point? Is that
Okay. That's not what I got. I don't know what I put in. Okay, well, we'll go with this. Okay, so how many years is that?
That's a day.
That's days.
Almost 30.
2.8 years? Yeah.
It's about 3 years. Okay, so the recommendation is that they have an eye exam and then at least in 5 years they have a repeat. So it produces a retinopathy. The picture that you have there is that bullseye. This is a very typical for Plaquenil toxicity. It can eventually lead to vision loss. So at this dose per day, the risk is still fairly low. They need to be monitored, but the risk is low. It's higher with chloroquine, but we're using hydroxychloroquine. Doesn't have the same risk, but because of that cumulative toxicity, that's why they need that that follow-up. How many years have you taken it?
On and off together, it's continuous at least 8 years.
8 years.
But I have to see mine every 6 months if I'm on medication.
So you're past that 5-year mark. Did they ever make you? Did they ever give you a greater length of time in between?
A year, but my doctor advised me 6 months.
See, for malaria, they do at every 6 months. But here, the recommendation is 1 year, the baseline, and then 5 years. And I think it's because of the cumulative dose. Usually under that, most people don't get into trouble. Interesting. Okay.
I wonder if that's just new guidelines they've set, because my mom is every 6 months too. And she's on one for that. And I don't think she's been on it for years.
Don't know.
My mom and I take it every year. Do it.
It won't hurt. It won't, it doesn't hurt. Let's see. The recommendations are also is to make sure patients report any visual changes. So just get educating them about that. Okay, the last 2 pages are the anti-TNF alphas and the non-TNF alphas. Mostly what I want you to see there on the page 22 is as you go down that adverse risk, what you'll see as a theme is increased risk of infection, and you'll see some of the cancers popping up. But the other thing you'll see is autoantibodies. So these, since it's a biologic agent, the body sometime will respond with antibodies, and that will decrease effectiveness. The one that is most significant in this group is infliximab or Remicade. You have to give it with methotrexate in order to not produce so many autoantibodies that you render it ineffective. So that one is always used in combination. Most of these are given, these are all going to be given by some type of injection. The Remicade is, I think is an IV, yeah, it's an IV infusion. So it is a pre-treatment because of the infusion reactions, which can be like a hypersensitivity reaction. On the last page, these are the non-TNF. You'll see through here the same thing, increased risk of infection, increased risk of cancer. The one I want to point out is rituximab. It is one that you'll see a class effect reported on this with this group that it increases the risk of heart failure. It really is mostly due to Rituxan, and you'll see it in there is that it can worsen heart failure. It's really the one that stands out in that group. The rest of them, if you know you can apply almost the same to every one of these, and then they have their little differences. That's what I would learn. Questions? It's actually, from the time that I was in your shoes to here, has become a much better treated disease. And it's fairly logical. I'm not asking you to know a lot about each of the individual drugs, but as classes. If you'll do that, then you'll have down the big stuff that you need to know at this point. Okay, so I think I'm right off the bat first with the cases, so I can just go over my case and then I can hand you off to Dr. McNeil. Would you like to do that? Okay. So the case I brought is gout. So you might get your gout handout out.
I heard that's why I wasn't.
That's nice.
Like the methotrexate.
Oh, okay. How do I get those back on? Oh, hit the system.
I just have it in the blue ball and then go to
Doctors went back to doctors.
Are they on the always liked that one. I can't find it anymore, but. Okay, so here's your person. 48-year-old, 200 pounds, 72-inch male, complains of severe pain at the base of his left great toe and around the forward portion of his arch. Pain started 2 days ago after a long walk, severe enough to wake him from sleep. Pain was made more constant, or became more constant the next day, causing him to limp. Pain became more intense, gnawing and constant with no abatement. He describes it as a tightening, vice-like pain that is constant squeezing pressure sensation. Today he can't bear weight or tolerate bed covers. On physical exam, the first metatarsal joint is warm and tender to touch. Periarticular area is erythematous, swollen. Current medication is HCTZ, amlodipine, levothyroxine. He drinks 6 to 8 ounces of wine every night with dinner. So which of the subjective and objective history are compatible with the clinical features of gout, and what lab and objective data would confirm the diagnosis? So take a couple of minutes, look through your notes, make notes, and then we'll talk about that.
What's the vice-like mean? What? Vice-like? That was a German. Tightening, describing the pain. He describes it as a tightening, vice-like pain. Maybe like of the vice.
Extremely strong, like a vice.
You don't, I think Dr. McNeil's going to do it. I think he told me he was going to do it. He told me personally. Now, where he's embedded it, I have no idea.
What are they talking about?
Because I asked him, I sent him a note, I said, are you doing a clean med of these this week? And he said, no, next week. And he listed them specifically. I hope so, because what I gave you, you couldn't diagnose it. What I gave you. Okay, if you got it, you got subjective? Okay, Taylor, give me the subjective that's consistent with gout.
The pain, especially during sleep, like not being able to have the bed covers touching it. The food that he eats, like excessive alcohol could cause it too. The type of pain he described, the fact that it's in the big toe.
Okay, what else? Anybody?
Is that a diuretic?
He's on a diuretic, okay. What else about the way he's described the pain?
Constant. Tightening.
Worsening, so remember it starts and it intensifies rapidly. So usually, I think I told you 8 to 12 hours. So he's giving you something like that. That type, Vice-like grip is common. Not being able to tolerate bed covers, that's really common. Neuropathic pain will also do that. Okay. So what about objective?
Hot? Swollen.
Okay, say it loud.
Red, swollen, and hot.
Okay, and then the joint itself, tell me about it.
That is the fudge and big nose.
Okay, and why is that the most common one? Furthest away, lowest temperature, the uric acid precipitates out at lower amounts at lower temperatures. Okay. So you identified HCTZ as a possible cause, the alcohol is a possible cause. Anything else about his personal history? His weight, so he's obese, more common. So what lab and objective data would you like to, instead of, what is your differential? What other things could it be? Infection? So you could have a septic joint? What else have you covered that you could? Osteoarthritis, does it usually present like that? No, he's young, well, 48, I mean, he could. RA can present like that. What else?
It's a kind of fracture or trauma.
Okay. Anything else? Did anybody talk to you about pseudo-gout? So pseudo-gout will present just like gout, except when you do the aspirate, it's not uric acid, it's calcium. It's a different crystal. That's why I'm sorry I can't call it. So pseudo-gout, the other one would be psoriatic.
It's calcium.
What calcium salt, what does it say?
This just is calcium crystals because it's in Google. Calcium pyrophosphate.
Calcium pyrophosphate, okay. All right, now, based on your differential, what kind of lab do you want?
Uric acid.
Uric acid?
And an X-ray.
Want an X-ray? Good.
CBC.
Pardon?
CBC.
CBC, what are you looking for?
Infection.
Infection?
Yeah.
Overweight.
Okay, that should get you a lot. The other thing you definitive would be a what? Aspirin. What would you expect to see on X-ray? Can't see the tophi, not really. What swelling? Yes. Can't see the crystals. You have to do a different kind of. You have to do a different kind of study. It's like light microscopy or something. Swelling. So usually you can see joint damage. You can see erosive. Depends on how long it's been going. What else? Anything? Okay. Let's see what we get. Okay, so here's his foot. Here is the X-ray. So all that is soft tissue swelling. You can see some joint. You can see some of his. That space is limited. It's not clear. And I wish I could tell you what that is. If you can look it up, what you do to find that it's some kind of light microscopy. I don't know if it's something you send away or how you actually get it. If you could draw some fluid out, that would be your best, and that's the only way you'll be able to get your definitive diagnosis. Okay, so that's your guy. Just speak up when you find it.
I will.
Okay, so here's your lab data. His uric acid is 10.5. What would we like it to be?
Less than 6.
Less than 6. His H&H is 10 and 48. Is that normal? Yes, you guys should know you should at least know a hemoglobin. If you know a hemoglobin, you can figure out the hematocrit, which is 3 times. Serum creatinine is 1.2. What do you think about that? It's a little bit high for a man his age. His BUN is 14, so that ratio, is that normal? Yes, it should be what? Your BUN to creatinine ratio is what? 10 to 20 to 1. Okay. And then his creatinine clearance is 96, it's stage 1, so it's deemed normal for him. His white blood cell count is 6,000, is that anything to worry about? No, what's usually normal? It'll depend on your lab, but what would be a normal range? 4 to 8, 4 to 10, so he's within normal range. Radiographic findings, he's got asymmetric soft tissue swelling overlying the metatarsal joints. Bone mineralization, joint space is well preserved, joint aspirate, so he's got a large number of PMLs and urate crystals. Anything?
I think it's
Polarized.
He found it, it's polarizing light microscopy.
Oh, there you
But
go.
I think you do that with the aspirate, right?
Mhm.
Yes,
Okay.
yes. Polarizing,
Polarized light microscopy.
okay. Look that up on your lab sheet. Let's see. So that is what they would see in the lab and then tell you, so they light up. Okay, so which of the following medications is most appropriate to treat his gout? Naproxen, colchicine, intra-articular corticosteroids, or oral prednisone? So just think about it for a minute. Think about what you're treating, what circumstance, and what's the first step.
Did he come 2 days before? Is that what that one was?
Oh, let's see. That's a good. I think the pain had started 2 days ago. Pain got just.
Yes, yeah, 2 days.
Sorry. Okay.
Do you know his renal? What was one of the guidelines?
Yeah.
I think it's greater than
What was his creatinine?
It was like 96.
First,
do the
First diagnosis.
Just if it's like or have only 1 or 2 actively inflamed joints. That's the only one you have.
Yes, you could.
Just 96.
So what are we dealing with? What's the circumstance?
One joint.
Pardon?
We're treating one joint.
Okay, so we have one joint, first presentation, right? Acute. Okay. So are those drugs appropriate for an acute gout attack? Okay. So then how do you decide between them?
I pulled out colchicine because it's after 24 hours.
Okay, so we're a little late for colchicine.
Naproxen, he has higher creatinine clearance, so we can't use it.
He's not so much, his serum creatinine is a little bit high, but when you look at his creatinine clearance, it could tolerate it.
Okay.
I wouldn't think you could totally rule it out because it comes out normal,
Okay.
close to normal. What about an intra-articular corticosteroid?
That would be the most appropriate.
Okay, so I'll tell you, they say that, but I'll tell you, you try to come at them with a needle, they can't stand the aspirin. So yes, it's possible, I've never seen anybody go, yeah, stick a needle in it. So, okay, yes, you could do that. What about the steroid? Will the intra-articular steroid completely treat him? Possible, but he's delayed a little bit, so he's like 2 to 3 days. It was 2 days ago? Okay, so what did we talk about in terms of when to start treatment? As soon as possible, and the more delayed it is, what does that mean?
The harder it is to get under
Harder
control.
it is to get them in remission, harder it is to get them under control, and the longer it takes. So he might do okay with just one shot, he may need something else. So how do we decide between those three? Y'all ruled out colchicine because you think it's too long. How do you decide between naproxen, oral prednisone? One is you have to look at your contraindications. Is there anything that you were given that is a contraindication to the use of naproxen? GI, heart, what else are you worried about? Kidney? Kidney seems to be okay. We don't know anything about his GI or his heart. So could you use naproxen? Yes. Oral steroid, could we use that? Might be faster, more powerful. So you could go multiple ways here. You could give him that, you could do the injection and put him on the non-steroidal. You could also put him on the oral.
As far as pain relief goes, what would you recommend as like immediate pain?
I'd do the naproxen.
You did the naproxen
Mm-hmm.
alone?
I don't think the intra-articular steroid, if you're going to do the intra-articular steroid, then I'd give him some naproxen. If you're just going to treat him by itself, then maybe the steroid by itself. So it depends.
Okay.
Sorry, there isn't a clear answer here.
If you do the intra-articular steroid, could you add like lidocaine to it to give him temporary?
I think they usually would do that.
Okay.
I think you probably do it before you stick the needle in to get the aspirin.
Okay.
So he's probably already got that in. I didn't think about that. Okay.
Could you still, this is kind of after, but could you still use colchicine for prophylaxis even though he's outside the 24-hour window? Like after?
Yes, you could.
Okay.
Yeah, you could. She makes a good point. You could put him on the colchicine after you've given him the steroid if you wanted to treat for like another week or so. Okay, so here it's not so much to get you to give a right answer as to think through all those reasons why you would use each of the drugs. And you have, or ruled them out, you've caught most of those. Okay, so the patient gets dramatic relief of the pain with the oral naproxen. After taking 500 twice a day for the first day, the pain symptoms stabilized and began to lessen. After 5 days, his joint was no longer inflamed, and he stopped the naproxen he continued for 2 additional days and stopped it. Is he a candidate for preventive? Why not? Pardon? It was 10.6. So just based, outside of his uric acid, is he a candidate to prevent? So what's the big things? He had 1 joint, first presentation. Is he likely to have another flare? Yes, we said about 60% of people will have an additional. But one of the criteria was we start treating after they've had 2 in a year on the second one. So more than likely, you wouldn't do that with him, but what would you tell him to do?
Cut out the wine.
Diet.
Maybe decrease the alcohol, what else?
Lose weight?
Lose weight. His diet, we'd look at his diet, see if we could reduce some of that. He's on that thiazide. So you might look for other alternatives. Maybe you could do an ACE inhibitor in the amlodipine. I don't know, it's not quite as good, but it might be a different way to look at rather than having to put him on now another drug. I hate when we induce a problem and then have to treat that instead of doing something with the base treatment. So after 8 months, he complains of pain in the base of his left toe along with the same pain in several joints of his left foot, including the left ankle. The pain occurred in the middle of the night. He took 3 over-the-counter Advil, so that's 600, which helps some. He also reports that he has had milder episodes of pain in the same region over the past 3 months, and each time he's taken Advil, even though it upsets his stomach. On physical exam, the first metatarsal joint is markedly, we got done early, so we just went ahead.
Good tray of happy
Markedly
cookies.
inflamed, tender to touch. His uric acid is 10.5, his hemoglobin is 12, his serum creatinine is now 2.5. So which of the following medications should be used in the treatment of his attack now?
This was the next day.
So this is 8 months later,
But
night after. So you're within 24 hours of the attack.
And then start them on. Yeah. I thought like doing that 8 on last one, just stuff as
One of those, you're,
Okay, let's dissect the case. What are the pertinent things in that case that are important to you making a decision?
We had one previously. This is the
He's
second
had
one.
one, so this is the second one in a year, so now we're gonna be thinking what?
Prophylaxis.
Prophylaxis or preventive therapy. What else is pertinent?
It's affecting more joints.
He's had, so we had one joint the first time, now we got multiple joints. What else?
Serum creatinine.
His serum creatinine has gone up significantly, so it was 1.2 at baseline, now it's 2.5. Most likely cause is what?
Advil,
Is the non-steroidals that he's been using. What else? His hemoglobin is low. He has dropped from 16 to 12, so what are you thinking there?
GI bleed,
Pardon?
GI bleed,
GI bleed. So you can lose as much as 10 to 15 mils a day if you take steroid or non-steroidals chronically. And the patient will never know it, just a slow bleed over a long period of time. So, in terms of what we have up there, we're still treating an acute attack, right? So what about indomethacin? What kind of drug is it?
oh, it's on the chart.
We'll talk about it very much. It's an NSAID, it's a very old NSAID. People don't use it as much anymore because it tends to cause a lot of fluid imbalance and it precipitates heart failure in a lot of older folks. So colchicine is what? Would that work in this man? Yes, it could work because he's come in pretty quickly. And as far as we know, we don't have any contraindications to it. What about intra-articular steroid?
Too many joints.
He's got a lot of joints. Could you use it in some and not others? Yes, you could. You could choose to do it in some and not the others. Oral prednisone?
I would do that.
Pardon?
I do it for a meeting.
It would get all of them. So since he has multiple, you could do that. We'll ask Dr. McNeil. So when you've got people with gout, when you come at them with a needle, what do most of them do?
I was just they're wincing. You know, you can get the first two in, A and B, but it's D, but you're not gonna get near a gout. You're not gonna get
I
near.
told you. That's why I told him, because this intra-articular, I just usually laugh because I think most of them won't even let you do the aspirate. So do you usually do a lidocaine before you aspirate it?
I've never stuck a needle in.
You haven't? Wow.
No, guys, if you didn't have all of the other stuff going on here, if it was just you coming in
Uh-huh.
with this, then indomethacin clearly.
Yeah, he's right. It's very powerful, and it'll do the trick.
And by 11 o'clock tonight, you'll be better.
He is right about that. A lot of people will shy away from it just because of the side effects, especially in older. His serum creatinine is too high to do that. But the residents I trained with must have been needle happy because we aspirate everybody's joint. But people would just scream.
Would indomethacin have been good for the first,
Yeah, you could have done it. You could have
and
done
his
it.
kidneys were closer to?
His kidneys were good.
Colchicine works really well, really fast. I think I've only done that maybe twice.
I've done it a lot. I told them we used to dose it till they were toxic and then we back off. You know, we give them like 0.5 or 0.6 every hour until they threw up or had diarrhea.
The thing about colchicine that gives me the heebie-jeebies is that we used it in research because it prevents neurotubule assembly.
Yeah,
And so it blocks neurotransmission. It's not why it's used here, but
Right.
you give somebody a drug and it's gonna go everywhere.
yeah.
What are you doing to the nervous system?
You know, it doesn't really have that many, at this dose, doesn't really have that many neurotoxicities. It's the GI that gets people. Interesting. Okay. So here, probably you could do the colchicine or the oral prednisone, probably be your best. So then, says he's had 2 attacks, and we'd want to watch his kidneys. So then what would be your preventative?
Did you say the oral prednisone?
Uh-huh.
And so how long, if you give somebody, you're gonna give them 60 milligrams of prednisone or something, how long is that gonna take to work?
Well, it won't be as fast as the colchicine. It will be within a day, they'll get significant. I mean, since he's had multiple attacks, then it is going to probably take a little bit longer. But I would say within a day or two, he's gonna start doing better. But we probably have to treat him for 10 to 14 days.
So if you're gonna do that, if you're gonna use prednisone, you're gonna have to give him something for the pain. Because these guys on a gout flare, I mean, they're there.
Well, with the multiple joints, yes, I think you're right. So there you might pick your biggest joint and inject it. I have seen you do other stuff that I don't, this squeamish act is, I don't know where it's coming from. Okay, so prevention, so what would we use?
Allopurinol.
What is our goal with prevention? Lowering the uric acid level, okay, prevent acute attack, what do you mean? Preventing other acute attacks, okay, and the complications of gout. So if we start, which of those up there are prevention? Allopurinol, probenecid. How are they different? What's allopurinol do? Production or excretion? Production, it decreases, it's a xanthine oxidase inhibitor. So it decreases production. What's probenecid do? Excretion, it gets it out, it gets more of it renally excreted. How do you decide between the two?
Kidney function?
Kidney function was one. His kidney function here right now is too low. He won't excrete enough of it to make a difference. If his renal function was normal, then how would you decide? Probenecid is best in which people?
Under excretors?
Pardon?
Under excretors?